Welcome to the Healthcare on the Move podcast, your gateway to understanding the future of clinical mobility. We bring together healthcare executives, IT leaders, and technology innovators to uncover the strategies that turn mobile technologies into powerful tools for patient care. Each episode uncovers the real-world insights that are reshaping healthcare technology. Now, here is your host, Myron Wallace.
Hi, today I'm joined by two leaders from BlueFletch, Brett Cooper, founder and chief operations officer, and Lee DeHihns, chief revenue officer. BlueFletch has spent years in the single sign-on and frontline enablement space, and they're now heavily focused on solving one of the biggest friction points in healthcare mobility, making shared devices actually usable, secure, and scalable for care teams. Brett, Lee, welcome to the show today.
Thanks for having us on, Myron.
Thank you.
It's awesome to be here. So, one of the things that, we're focused on Healthcare on the Move is we talk about tech, workflows, and frontline realities that are really shaping the care delivery side. And I thought it'd be great to dig into the reliance on shared mobility. Mobility's been around in this space for quite some time. And now we have tablets and other things coming into that sphere with wearables. And it's not necessarily a nice to have at this point. It's really something that's part of the orchestration and care teams are looking to employ. And, you look at the hardware that is being utilized, and are the apps in the right place? Do they have the right tools? And access is still very clunky. Looking back to the years that we've all spent in and around this space, it's painful to sign into devices, and not everyone has the standard across applications. So we look at, these things around like clinicians on the move and adoption and, how they work. So how is BlueFletch really helping care teams with this type of challenge in today's time?
Lee, you want to field that one?
Yeah, sure. Happily. I'd say, BlueFletch entered the healthcare space probably about 2.5 years ago, actually initially because we were getting requests coming into us from healthcare organizations that were facing some of the same challenges that we've seen with some of our retail, manufacturing, and logistics customers. Specifically, in an environment where there's a shared device, we need to have our frontline workers, in this case clinicians, be able to come in, start their shift, pick a device up, log into that device very quickly, and automatically have access into the applications that they need to perform their job without anything more complicated than an NFC badge tap and a PIN, or even facial recognition, or I would say worst case, username and password. And then once that occurs, you're going to know where that device is, who is on that device, and what applications they're using it. I think as the mobile device environment becomes more ubiquitous in healthcare, there's a desire to standardize that. Whereas I think over the past several years, it's been a little bit more ad hoc, or it started with people bringing their own devices. And then depending on where you work or what your role is, you may get a device signed to you, or you may be asked to use, your current device that you own and bring with you. So there's tends to be more of a unification around it. And that's really how we jumped into that space. And I'd say over the last year or so, we've started direct outreach into that same arena as well, and been really pleased with the feedback we've been getting.
So BlueFletch has been in this space for quite some time. You have not always been in healthcare. And kind of backing up for a second, like where did BlueFletch originate from? Like what was the primary verticals that you all were in before you got into healthcare?
Yeah. So over the last, I would call it 16 years, we've been working in the enterprise employee space. So when you think about these large retailers, whether it's Disney, Delta, Home Depot, we've worked across a lot of those, building apps specifically that those companies needed for their employees. Around 2011, we actually started building internal accelerators for problems that we saw over and over again. And one of the common ones across all those organizations was, you have these shift workers that pick up a device, they have to log in, they'll have 4 to 10 different apps that they're logging into. And sometimes they'll, take a break, have to relog back in, and, 10 logins per day times 20,000 employees gets really, really expensive really fast when you multiply that times 365 days a year. It's a multi-million-dollar problem. So we built these tools originally, started deploying them to a lot of the enterprises, which would be retail was probably one of the early adopters of mobility because they realized that when you have a retail associate on the floor, that's time they're not going in the back room to go to a computer. They're not having to go, leave a customer that may be out there. So there's a lot of value to be achieved there. And then warehouse logistics followed. And then I feel like with healthcare, it is in, you could probably speak to this better than I can, but there was a lot of like the workstation on wheels was the standard for such a long time. You put a Windows workstation that either the nurse has to go back to or the clinician has to go back to, or you have one in each room, or it's on a cart and they wheel it from room to room. And that was the de facto standard for 15 years. And then
it's still there, by the way.
They definitely
it's still there.
Yeah, there's a good like 40-50% of hospitals that's still the primary use case. But I feel like there was also the DEC phones or the VoIP phones that got introduced in the late 2000s or early 10s, and those have turned or morphed into these actual smart devices, which iPhones led the way with a lot of their strong integration with Epic, and then you had these Android phones. So sort of the natural evolution for us is we've been we're on millions of users are using our software across these other enterprises, and like Lee said, we had a number of healthcare organizations reach out and say, hey, we would like that same solution that we saw at X retailer or at that delivery company.
So who all plays in this space? There's a lot of, when you think about like MDMs and shared devices, where is the almost like the divisional line between like MDM versus the BlueFletch ecosystem? And then like who else is in this space?
That's an excellent question. I think I'll talk about the MDM space, and then Lee, maybe talk about some of the other players that are outside of that, or even some of the competitors we run into. But the MDMs, and from a just definition standpoint, MDM is a mobility device management software, or sometimes known as EMM, endpoint management. And the tools there. So originally there were some legacy players that handled Windows CE devices. I actually worked for one in the 90s that got bought by SAP. But over the years, these tools have gotten more sophisticated. The big ones were Workspace ONE, which was originally named AirWatch. It's gone through a couple iterations. SOTI, which runs a lot of different, it was originally Windows and then went into Windows CE, went into Android. And then Intune, which was Microsoft's product, originally came out sort of as an add-on for Microsoft's other stack. And those tools, all of them have the ability to manage devices, control it. They have a home screen or lockdown screen, and then they have some sort of SSO capabilities. A lot of it is based around Microsoft's MCell and Authenticator framework. So you do have an experience on device that the MDM will run. The problem with that is a lot of those, it just lacks the advanced workflows, which companies like BlueFletch and Imprivata play. And then I guess, Lee, do you want to talk about the other side of the ecosystem, like the BlueFletches, Imprivatas, and then the pieces it ties into?
Sure. So I would say the two big players in the space are definitely Imprivata first, and then BlueFletch second from market share within healthcare. In terms of what we interface with, it really depends on the ecosystem that is at that provider, but definitely we're going to have integrations with the MDM regardless of what that MDM is. Typically, our home screen that we call the launcher that the user interfaces with is installed on that device via that existing MDM, whether that's AirWatch or SOTI or Intune. And then from an OEM perspective, so the device manufacturer itself, whether it is on the Android side with Zebra, Honeywell, or Samsung, or on the iOS side, obviously Apple, we're going to have specific features and functions that integrate with the device capabilities. So think of things like EMDKs that can access, microphones or cameras or things like that.
And what does EMDK stand for? What is that acronym?
It is Enterprise Mobility Development Kit. Is that right, Brett?
You got it right.
Yeah.
$5 for Lee.
Yeah.
We'll give you a trophy at the end of the show. Don't worry.
It's it's a set of APIs that applications and vendors like the MDMs and BlueFletches of the world can actually use to improve the capabilities of the devices for end users.
And
Okay.
what we've seen, particularly with on the shared Android side, that has effectively been the structure through which you can create the scenario on the device from a user experience, from a functional and device reporting experience that really is going to meet the needs of what that frontline caregiver is going to be doing on that device.
That makes sense. I mean, it's great that all those APIs exist. So it MDM and AirWash and all these other platforms don't solve the single sign-on challenge, which a lot of folks seem to think that they can get by with that. But when they pick up the device and try to sign in, I think it's a different disconnect there where it's like, oh, I didn't think about all these other applications that people are signing in and out of, and that's really interesting to hear. So where do you think that organizations underestimate the complexity with these things? Because they seem very complex. We know they're complex, but I think it's good to just talk through like why. Why does this exist?
I think a lot of it, and I'm interested what Lee sees, but for me, a lot of it feels like integration issues. So there's software that you've purchased or rolled out over, let's call it 20 years. So there's different iterations built on different standards. So you may have something that was built in the late teens that's still running your username, password in a database somewhere. And then you may have something else that's built on a standard called OIDC. And then you may have a Microsoft app that runs on Microsoft specific language, so MSAL. So you have these different integration points that may not be compatible, that you need a piece of software like a BlueFletch in the middle that can handle talking to all of those and brokering that. So integration, I feel like, is a underestimated piece in a lot of organizations where they think everything's just going to work together when you throw it out there. And it like you said, Myron, it will break a lot of use cases as soon as you start being like, well, we also have this app and this app. And then you find that you have bought something 20 years ago the nurses are still using, and it's critical to their business, and you have to be able to support it. And Workspace ONE just supports this one type of language in this model, or if you switch to a different one. So that's what I've seen is really the breaking point that a lot of people run into, where as they start diving into it, they're like, oh, we need a BlueFletch to sit on top and solve this problem, or we need a provider to solve this problem. I know, Lee, are there other points you've seen that where it causes a breaking issue?
Yeah, there's almost the opposite side of the coin of the underestimating the complexity, where the complexity might be known about or acknowledged on the surface, but then somehow swept under the rug. And it tends to be a pile that just continues to grow as a lump under the carpet. And so, a conversation could be what Brett was just talking about from the perspective of, we've got 12 apps that have all rolled out over the last 15 years. They may authenticate through different methodologies. Nurses are used to username and password, so we'll just let them do that. But when you look at devices deployed at scale, sometimes in the tens of thousands across a workforce that is working in a stressful environment, if they have to stop and enter a username and 14 to 16 digit alphanumeric password, that really slows things down. And it's going to delay care. And then in some cases, we've talked to so many frontline workers, if they have a tool that's too hard to get to or too hard to use, they're just going to avoid using it altogether. So then you run into situations around lack of documentation, particularly where that's incredibly important from a charting perspective within patient care and patient outcome, patient communication, or patient communication about patient care between caregivers is absolutely critical to increasing improved outcomes. And I think you look at like, well, it's not that big a deal to have someone enter a username and password until you really start to unpack all of the issues that are downstream from that.
But don't you also have like an issue with information security at that point? Because what if, the device is picked back up and it was signed in underneath the previous user, and they have access to, chart something or order medications because they were credentialed differently? That seems like that's a huge security risk.
It's a security risk and also a care risk. I've talked to people who have charted cases on the wrong patient because they just pick up the device and it's logged in, and they're automatically, you're working so fast and it's perhaps a high stress environment. You're not even thinking about, am I working on John Smith instead of Joe Smith or something like that? You're just moving as fast as you can to chart. And that creates huge problems after the fact, not to mention the security and privacy risk that you talked about.
So one thing to back up on, when you look at the MDMs, it's my understanding BlueFletch has a certain set of capabilities that are really beyond the other market players that you mentioned that are in the competition space. So you guys recently introduced some voice calling capabilities, and you have some other management tools that are sort of that separation between like MDM, EMM, but then also like enterprise communication set. Like I think it'd be good to discuss that. Like what else does BlueFletch have in the product stack that's really different?
I can feel that one. So our product, and this just really goes back to how we've built this company over the last 16, 17 years, is we build everything based on a need. We're not like pulling some crap out of the air and saying, hey, let's throw AI on top of blockchain. And
so you're telling me you don't take every customer request and build what they want?
We take a very, very large amount of customer requests, and we do a full scale analysis of it, of is this a common problem we've seen more than once? And if it is something where, this customer X has it, customer Y has it, it's going to make it in our stack pretty quick from a development. And our product team does a really good job of new feature development. So a lot of these things that Myron just talked about is, we had a customer that came to us and said, we need to be able to solve for communication to a disparate workforce. We don't want to use Teams because it doesn't meet our security compliance requirements. It can, but it is a very high lift for them. So a lot of the features around, they wanted communication, but they wanted it simple, they wanted it effective, and they wanted to work on shared devices. So we built a chat solution specific for that. And we had multiple customers that were asking for this, and that really became that product. On the phone side, we've seen things where there are a lot of VoIP apps out there. Zoom is very popular other places. Even Teams has VoIP calling. Cisco has their CUCMA. A lot of these things are designed for a fixed device. They're not designed for shared devices that are used by multiple people in shift work. And we took a step back and said, hey, the requirements we've seen over the last 10 years don't map up to the landscape of the products that are available, and tried to integrate with certain products, and they just didn't want to support it or didn't have a need for it. So we've really built a lot of these pieces specific to things and problems that our customers have articulated. And then the last one, Myron, you mentioned, just on the MDM side, there are Intune is a big MDM used by a lot of customers, and it lacks what I'd consider certain table stakes enterprise features. So we've built a set of tools that actually sit on top of that called Playbook that allow enterprises to have things like sequenced installs, be able to have retries, do things that you don't necessarily get out of the box with an MDM like an Intune. So those add-ons on top of that core BlueFletch experience are things that are really driven by the need in the marketplace that's just not being met by those MDMs or some of the other tools.
Oh, that's great. I think like the next thing that, I think would be great to talk about is, why healthcare, institutions look at BlueFletch, like what's going on in this shared device space. Where's the market really going with the devices? Do we see like full convergence? I know we talked a little bit about like the workstation on wheels, that's set there, and there's an opportunity to mobilize more of this. So what does that look like? And really think about too, like what's different between healthcare and like all the other verticals that BlueFletch has played in historically to date?
Yeah, I think, it's interesting. It's an interesting question you ask. And we mentioned that there's still a huge proportion of workstations on wheels. There's also still a large prevalence of iOS devices, primarily because of the tight integration between Epic, which is the largest EHR in the United States, and iOS. But that ecosystem is opening up with Android and Epic becoming more integrated as well. And I think the ability to have Android devices enter the conversation, I think they're around 40% of the market right now or so in healthcare. Brett, keep me honest on that number. I don't know if I'm pulled that out of whole cloth, but I think I've heard that at different conferences over the last year.
It's between 20 and 40, depending on who you talk to. Yeah,
that's true.
If you talk to Apple, they'll tell you it's about 10%, but it's definitely a lot higher than that.
Yep. So what's interesting there is the deployments and the integrations that you can do from a experience perspective from an Android device. And I think what you're seeing there, what that means is it's truly meant for a shared environment, and truly meant for a unified experience across each of the people that are going to be using this device from shift to shift. So what that means within a healthcare specific scenario is, with incorporating BlueFletch into that, there's the ability to clear the data on device in between users. So if Brett and I are both nurses on the same floor and we're changing shifts, we can literally hand that device off from one person to the next, do a badge tap, log the other person out, log the new person in. I don't see any of that communication that's on that device that would be private and I don't need access to. It's going to be specific to my role. I would carry that through to the phone side of things, where the phone is following the role and not the person. So you want to call the charge desk in the ICU. You don't want to call the person working that shift. You always want to get in touch with that person, regardless of who has it. So I think, there's that side of it that's really opening up that standardized environment. And I was talking to someone the other day that brought up an interesting point in terms of replacement of workstations on wheels. Oftentimes of those in a room, you may be a patient in a bed and your caregiver might come in, turn their back to you and be typing on a screen. And that's not the best experience from just feeling cared for, and being able to go into a room and face that person that you are caring for with your device in hand, doing the same things you might be doing on a PC that you're wheeling from room to room, really can add a lot to the clinical experience, not only from a workflow perspective, but from a patient experience perspective and therefore outcomes.
It's interesting that, thinking back to when this space first started, I got into this space about 10 years ago. And when patients would see care team members, using a mobile phone, they would instantly assume that they're on some type of social media application or texting someone. And we've pivoted from that, where it's like, okay, like now we've become almost accepting of them using the device, that, it's not, hey, this is not just them on social media. They're actually doing something, that's, for my benefit. And it's good to hear, like, we've kind of transitioned into that. I think that, something else that I was thinking about the other day in conversation, like, where does BYOD play into this, and how does that work with BlueFletch? Because it seems like there's a lot of institutions looking at, hey, we'll just do BYOD. We don't have to own the devices. We don't have to go through this capital expenditure, and we don't have to support it. We'll just do BYOD.
Yeah, I got some thoughts.
Really
on this.
messy. Really messy.
So it's a fine line, and it is messy. That's a great description of it. And it's always one of those things. It depends is sort of the real answer. So, with BlueFletch, we do support single sign-on on Android devices. We support it on iOS devices. We support it on Windows, desktops, and tablets. But with iOS, one of the things we've seen a lot of is, I'm going to call it I'll pick a retail and manufacturing. Leadership teams want to have iPhone devices. They don't want to carry a rugged mobile device, especially when they're traveling from site to site in their region. They want to have an iPhone. We have the ability to run a containerized, secure, effectively company instance inside of that device using the BlueFletch solution. And that is the same thing for healthcare. So in healthcare, if I'm a nurse and I have, they're using shared iPhones, you pick up a device, it's running everything in a secure container. So you don't have to worry about the issues with iOS not locking down your data or protecting things, because it's secured and containerized. But on the BYOD side, what we've seen is there are a lot of doctors, particularly who want to be able to access certain systems when they're not in a facility, or don't want to have to go get a mobile tablet or an Android tablet off of a rack somewhere. They just want to pull their iPhone out, be able to badge tap and get their solutions. We support that as well. So I think that's the scenario where BYOD fits the best in a lot of these. And when you think about how, doctors have contracts, they're not necessarily an employee of that hospital. They're a contractor in most situations. It fits well with that model. I think the flip side, though, is there are organizations that are like, let's have our people bring their devices. And that BYOD model, a lot of people are really reticent on that. They don't want to do that. They won't have to worry about their personal information being stolen by the company is what they're worried about. And vice versa, the company is worried about the employee taking screenshots and accidentally uploading it to their Instagram. So I think there's the primary use case for BYOD, I think is the way BlueFletch structures it, where it's a secure containerized model that you can't have data sharing across it. That's really the only way to do it in healthcare or any other high security, high compliance environment.
So it sounds like for the IT folks that are listening, it sounds like virtual desktop, except for now in a mobile experience in some ways.
Precisely. Yeah. Yes. That's exactly it. And that, I think the other advantage of that is, if a phone gets lost, especially BYOD, if a phone gets lost, you don't have that HIPAA potential data breach, or if you're, a federal device or government device, everything is secured in on-prem of a hospital or in their data centers. You don't have to worry about losing data.
I would think if I'm at the point of care, BYOD sounds, back to the comment I said, messy. You're around, bodily fluids, you drop your phone, then it's like, okay, you wipe it off with a Santa cloth or some type of, material to clean it. And then you go home and like your kid's touching it or something like that. It just seems really kind of disgusting. I'm just going to say that.
You're just gross. You're grossing me out right now, Myron.
Yeah, I mean, it's
like my kids come home from school and I'm like, go wash your hands. Go wash your hands. Drives me nuts. But yeah, I think that's with these purpose-built devices from Zebra, Honeywell, Datalogic, Spectrum, they have the ability to clean those and they can withstand harsh clean. With BYOD device, there are certain devices where if you start wiping it down with an astringent or a strong cleaner, it's going to peel the paint off the back, or you're going to have issues with that device not performing so well after you wipe it down a couple times. So I think that's a really good reason why these organizations need to look at the purpose-built devices that Lee was talking about.
So maybe if you're in the furniture restoration business, maybe you need to get some of these cloths, right? So you can strip the finish off things.
I think another side of it too with BYOD is none of those are rugged devices, right? So despite the fact that people don't think of healthcare as a rugged environment the way a warehouse might be, it very much is. There's equipment getting wheeled in and out of rooms. There's very large beds that are getting wheeled around. There are stands with sensitive machinery on them. There's a lot of people walking around, in some cases, very quickly, preoccupied with caring for someone while they're moving them. There's a lot of opportunity to drop your device from a decent height onto a floor, and hopefully there aren't any carpets in any hospitals any of us have been in. So
only the bathrooms, Lee.
Oh, please. Okay.
I one of the things
whoever came up with that in the 80s, I'm just going to say, like, or 80s or 90s or whatever era of time that was, to put carpet in bathrooms. Come on, man. Like, that's not cool.
Oh my goodness. It's one of the points just I thought of as Leo saying this, there is the flip side too, that there was a period of time where some of these organizations said this is the device that nurses should carry, and it would be a large device that you would have somebody in a warehouse carry. And imagine,
like the days of Nextel, right?
Yeah, imagine you're a nurse, you're wearing scrubs, and somebody hands you a giant boxy device. You're like, I would rather just have my iPhone that fits in my hand, is designed to be carried all day, and they just wouldn't carry those big boxy devices around. So I think a lot of the manufacturers have started to recognize this, and the newer healthcare devices are sleeker, they're lighter. They can actually fit in a pocket or in a holster without pulling your pants down. And, at the end of the day, like, it was I'm going to call it a lack of good product feedback on some of the manufacturers for the products they're putting into the field and expecting nurses to want to use them, want to carry them around.
Mm-hmm. Yeah, I think they assumed that everyone was going to be back to the 80s bag phone era. And
Zach Morris.
Yeah, exactly. Or the, what was it, the StarTAC,
StarTAC, yeah.
We're dating ourselves here. We're showing our age.
I'm not old.
So only 23, right? So table stakes wise, like, what do you need to play in this space? Like, what type of certifications? Like, what do you hear from customers that you're interfacing with? And what seems to stick out as sort of the baseline requirement? The other thing I think would be interesting to talk about is, you look at, who's dominating this space right now from a EHR perspective, and why do we think that is?
Lee.
Yeah, so I think as far as table stakes are concerned, it's interesting when we're on initial calls with um, healthcare providers. One of the very first questions they asked is, "Are you certified with our EHR?" And obviously, are you HIPAA certified as well? So I think those are generally the first couple of things that need to be cleared right away. Otherwise, the call is ending immediately. With all fairness, so I think you have to be prepared to be able to accommodate those needs. As far as the EHRs that we've seen that are most prominent, the largest that we've encountered by a decent margin is Epic. Brett and I recently worked with the rest of the BlueFletch company to do a survey on, I believe it was around 300 nurses, and I believe 40% of the market was Epic, followed by, somewhat surprisingly, Meditech, and then somewhat surprisingly as well, Oracle Cerner was farther down the list than we thought it might be. And I think some of that Brett and I talked about could be due to the fact that some of the nurses who answered that weren't necessarily in hospitals, but maybe in urgent care clinics or more remote health or home health care or things like that. So it's a pretty diverse landscape in terms of the EHRs that you might see out there. But generally speaking, it's a decent bet that Epic is the largest one, I'd say, across the board.
And there's convergence, right? There's a lot of systems that are looking to go to Epic off of other EHR platforms is what we're seeing as well. So it's sparking this conversation around like what devices to use and really back to what you said, Brett, about devices that are purpose built have its place. I think one thing that we've been seeing in conversations that's really been paramount is the whole workstation on wheels replacement. Talking about that for a second, because now you can dock a lot of the purpose-built devices and get a full desktop experience, and you can go in and out of mobile to web type applications at ease for the care team. So BlueFletch works with all that, right?
Yeah, we do. We have, we can do that on virtually any device that is being deployed from an OEM perspective. And there's a couple different docking solutions that we can integrate with as well. Some of the ones are actually where the dock is actually a physical dock, but we also have the ability to do what I would call the virtual dock, where you're actually walking into a room and pairing with something that's connected to the television. So
is that the wireless experience is what you're referring to?
Yeah, exactly.
Okay.
Yep.
Okay.
And there's a few different providers of those as well. So I think that somewhere in that shared device, but with the extended desktop, is where I think we're starting to hear more and more questions about that. So if I had to guess, 36 months from now, that I think that could be a lot more prevalent than it is today. And we're starting to see it grow already.
So how does cyber play into, because that's been another topic that we keep bumping up against right now, because when you're deployed with the workstation on wheels, like if we roll the clock back to something about maybe a year and a half ago, CrowdStrike had their issue. It hit a lot of Windows workstations. Health systems were grappling with, we have to deploy our entire IT team plus like other folks to like get us out of this situation. So moving more things into that mobile sphere, having stuff
I think I have a strong opinion on that in general. So one of the things that I always advocate for is enterprises, whether it's a hospital, whether it's a retailer, whether it's a manufacturing firm, you need to have control of what gets pushed out to your devices. And one of the things with that model that CrowdStrike has, if you have a third-party vendor automatically pushing things onto your devices, you run the risk of them breaking something. And this is one of the biggest drawbacks I've always had with iPhones. We had a very, very, very large customer who Apple decided to change a bunch of APIs for. And the customer, their CIO told us, Apple would never do this to me. I'm one of their biggest customers. And then Apple proceeded to break their 30,000 iPhones. And, at the end of the day, like, one of the biggest advantages I like about these shared manufacturers, so be it the Honeywells, the Zebras, the Samsungs, is you can control what OS goes onto your devices. You control the software through your MDM that goes on there. You can run regression testing against all of those before it gets pushed out to your devices. So I think a big thing I always advocate for is how do you have as much control? And I think the cybersecurity has, there's patches and there's updates on one side, but there's continuity is even more important than the other. So when I would always do security auditing in my previous life, a lot of it was thinking about continuity, DR, recovery. How do you get things back up as fast as possible? And I think, for me, when I think about the tools you want the tools that allow you to have that continuity. If a system goes offline, can you authenticate locally? Can you, do an offline auth to get into local systems that are inside the four walls of the hospital if they're losing power? So there's a lot of pros and cons around, making sure everything's patched all the time. But for me, continuity always paramount to that.
Are they really doing regression testing? Because it makes me wonder, that's a lot of resources, and IT teams are spread thin unless you get into some of these larger institutions where they have massive budgets to do this. So do you really see regression testing?
Yes, there are a lot of teams that are very thin, and especially with some of the economic changes in the last couple of years. There is the advantage, though. There are a lot of tools out there where you can do a lot more things automated than you used to be able to do. But I think the more mature, larger organizations are doing a lot more of the regression testing before they push out new big versions of things onto devices or onto their computers.
Will AI impact this and make it easier, you think?
AI will make everything easy, Myron. I'm actually AI right now. I'm not even talking.
We need to ask a trick question here to make
Yeah, and I guess so. AI is a tricky topic of, and I'd be interested. I know Lee talked about that survey he did with the nurses, and there was a lot of feedback there. But my thoughts on AI is that it is a tool that if you use it the right way, it can make your very smart people be able to move a lot faster and help enable them. When I think about nurses, nurses don't want AI to do diagnostics and to replace them. They want AI to be able to dictate and take their notes and do charting and all the stuff that's a pain in the ass. You spend 10 hours seeing patients and you have to do 2 hours of charting and documentation at the end of a shift. It'd be a hell of a lot easier if, during your discussion with a patient, the AI is actually handling 80% of that note taking for you, as opposed to, I don't really want AI being like, well, this patient has a broken leg and I'm pretty sure they need a amputation. Like that's not what doctors and nurses want.
I hope it's not that general where it's like you got a broken leg and it's automatically saying you need an amputation. We're gonna have big problems if that's the case.
I mean, it only hallucinates 30% of the time. What can go wrong?
Yeah.
There was that Silicon Valley episode where it got rid of all the bugs in the code because it just deleted the code base.
Yeah, Lee, what are your other thoughts on that AI, especially in the healthcare space, both on the device management and software side, and also on the nursing side?
So I think, what was really interesting to me in that nursing survey that we did was the openness to AI within the nursing community and the degree to which they say they're already using it. I think what it does bring up is the importance of an organization having an AI strategy and deciding how it's going to be used and putting guardrails around that. Is a very cool term and it is much more scary than it is cool sounding, but it is the shadow IT thing that we've talked about. So I think there's an aspect of this that could be shadow AI. So someone's just going to pull up the Chat GPT instance that maybe came on their BYOD device for free, but do auto dictation in there or something like that. And that's a huge problem from a privacy perspective, obviously. So if you can put guardrails around it and look at where the healthcare companies seem to be looking at AI is really in that ambient listening, the auto charting, the dictation side of things, but putting policies in place around that and making sure that you have unified applications you're deploying out there that they can use, I think is what the key is to that. And it's not terribly complex. It just is something that needs to be done.
It's interesting. I've said this on a few podcasts now and a few different forums that I've spoken at recently about, really the ethical AI of the future and then the governance piece. It seems still that that's not really been defined. It's loosely defined. I'll say it that way. It's not fully defined. And I think there's opportunities to come in and put those guardrails. I think about also, something futuristic is, these humanoid robots that are being, produced right now by Boston Scientific has one. Tesla's obviously moving into that autonomy class, as they recently said in their quarterly earnings call. So like we have this movement going in that space, and with those robots now knowing where things are in a facility, they can go fetch them, and a lot of that's going to be, really dispatched from the mobile device that the care teams are using, I think, is what we'll see in the future. And I really wonder, like, how does that play, into the whole single sign-on? Well, you have single sign-on into the robots. Like, it's just so far out there in my mind where I haven't wrapped my brain around it yet.
I always think about what we saw in the manufacturing warehouse world over the last decade with robotics. And, I've had a lot of discussions, and this is sort of the advantage of being in multiple industries. One of the things that somebody told me, it was a plant manager early on, is like, yeah, the robots were terrible. We installed the robots and they sucked. They would get broken, they would get lost, they'd run into walls. And he goes, after about 3 years of refinement and data, they are faster than getting a human to do certain tasks. And they're really good for certain tasks. Like, I need somebody to go over to this loading dock, pick something up and bring it back to this loading dock. You don't really want to put a human on a forklift, have them go over there and do that. That's a waste of a move when that guy can be doing something more complex. I think in the healthcare space, you're going to see a lot of this too, of I need somebody to go get a wheelchair. Do you really want to send a nurse or somebody who should be on the floor seeing patients to go do that? That's a perfect job for a robot. Or the other one, like things like, they always talk about this in warehouses, like dunnage and trash. So taking trash out is a job nobody really wants to do, but it needs to get done. And I feel like there's a lot of this in the clinical space where, clean a room, turn things over, take laundry down to the laundry, bring new sheets back up, things like that, that they are not good tasks to invest your nurses' times in. And a lot of times they're having to do those types of things. So I think the use cases are there to save a lot of time and allow the clinicians to be spending more time with patients as opposed to doing things that they don't really want to be doing, or, if you could avoid doing it, it'd be great. I think how you manage it and how you secure it is, it's a lot of the making sure you test it, be patient with it, and then just iterate on it as it goes.
Yeah, I think the environmental services type role, cleaning a room, the robot's going to see things, that the human eye can't see from an infectious perspective, and make sure that those things are clean. So those are good things. And I think the other area that keeps bubbling up is like meds administration. We know how dangerous that can be from an interruption standpoint. If a nurse gets interrupted, during that, that could lead to, giving someone the wrong medication or the wrong dosage of medication, where it's like, hey, if there's something there to say this is what you need, or this is the right, amount of, units to give, if it's an injection, that could really, change, someone's life if it was done wrong, unfortunately. So really interesting stuff. I think, one of the things that I wanted to make sure we talked on is like the caregiver aspect of using the BlueFletch ecosystem. Like, what does that look like from a day-to-day perspective? Where do they really see the glamour, the glory in this application?
One of the things that we've focused on quite a bit is that frontline experience. And so what we mean by that when we say that is it's really making sure that the caregiver has technology at his or her fingertips to make their job easier, and not something that's going to add an additional friction point. So an example of that would be, I'm coming in to start my shift on a floor as a floor nurse. I walk in, I'm get changed in my locker. I'm walking out. I go by the charge desk or wherever the devices are stored, pick that device up off a cradle. I'm logging into that with a badge tap and a quick barcode on the back, and I'm into the applications that are appropriate for my role. If there is something that I need to be doing at the start of my shift in terms of the 4 patients that I'm talking to or caring for on my shift, that there are tasks you need to surface, you can have those notifications there right at login. You can make sure that you can go through those one by one, so you can surface applications that are appropriate for the tasks that are most urgent. The authentication experience, I kind of glossed over it, but that it should be glossed over from the perspective of a user. We want it to be as close as possible to what they might experience on the device that they were looking at before they got to work, their personal device. So we're really going for that aspect, making it as usable as possible so that if there's a phone connected to that, it's ringing to that phone that they have because of the role they've signed into, not because they've identified themselves as, um, you know, Bill or Bobby or whomever is working on that device at that time. It's just the role for that floor for that time period is going to get that phone call.
And you can do fast user switching, right? So like if let's say I sign in and the schedule knows that I'm supposed to be doing this type of job function or duty, they can switch and say like, because the application, if I understand this correctly, the applications orientate themselves based upon the role itself, right? So you have like your fundamental things, but then you also have placement of applications based upon that role on the device.
Yeah, exactly. So, going back to the floor nurse, he or she may have different applications on that device or something they have to do at the start of every shift that are going to be very different from what a charge nurse is doing or what an ER nurse is doing, or even if you have these devices deployed to say phlebotomy or specimen management or even like material management, the same devices can be deployed across the facility, but based on what the primary activities are, you can arrange the whole workflow on that device to be appropriate for that person's role. So it makes a huge difference and takes a lot of the thinking out of it. Going back to one of the things we said at the top of this session is really just making sure that we're facilitating getting the job done and improving patient outcomes and not having someone look at a device and try to think about what do I need to do next on this device. And I really hope it doesn't require me to type in 14 to 16 characters to get to do it, because that device is going to get left on the desk. And the person is just going to do what needs to get done to make sure that patient is okay.
So the device, if something breaks on the device, because devices often break, but if you talk to the manufacturers, they never break, but we know that they do break, right? So if it breaks during a shift, it sounds like you could just pick up another device and sign in and pick up where you left off. Is that a fair assumption?
Yeah, that's correct. So the idea there, let's say, like you said, they don't break, but if they do break, there's, if it gets rolled over by a very piece of equipment, like a C-arm or something like that in an OR, you can just go back and grab another device, log back into that one, and you'll be ready to go. And, ideally, that's something that can be done from an operational perspective and an IT perspective to train the staff to know what to do in those situations. So, maybe they go put it in a, lack of a better term, like a bin by the charge desk, for example. And then end of shift, the charge nurse's job is to let IT know there's 4 that need to be swapped out from backstock or something like that. So it's an easy thing that can be swapped out. You can make sure that you're looking at device management shift over shift as well, just from tracking. Like I started out with 10, only 5 got returned. Who are the people that had those devices? Who last had them? Where were they in the facility? What applications were they using? So you can go talk to that person and say, hey, you were using this at 3 p.m. today. You clocked out at 5 p.m. Your device did not check back in. Where is it? And so you can really kind of go through that. You can use device finding tools on the device as well, but incorporating it into the workflow from a training perspective, I think makes a big difference.
I was getting ready to ask, like, where do you get the location data from? Is that something by the manufacturers? I know there's some folks in that RTLS space. Are you relying upon those types of systems, or is there something else that BlueFletch has?
It's a bit of a mix. Brett, do you want to field this one?
Yeah, I'll field that. So it really depends on the device type. So a lot of it has to come from the operating system. So when you think about a Android device, Google has invested a lot in their locationing services. So they have a what they call it a fusion driver. So it effectively uses all these different attributes to try to derive as accurate a location as possible. And it'll give you it'll tell you, if you use GPS, here's the estimated location. If you use Wi-Fi, here's the estimated location. If you're using the magnometer and beacons, here's the estimated location. And then here's our best guess at the most accurate location. So Android does a good job of this. iOS has a really good system around providing location. The flip side of this is in a lot of these organizations, if you have a newer Wi-Fi infrastructure, a lot of the newer Wi-Fi infrastructures include, with Wi-Fi 6 and above, it includes better RTLS locationing where it can feed that data to the operating system of these mobile devices. And so I think a lot of this is becoming table stakes. So it's transparent to the apps. They're asking the operating system, and they're able to get it from that. So we're deriving that from the operating system. The downside is that if you're at a location that has a 20-year-old Wi-Fi network, you're not going to get as accurate location data as you could if you had some of these newer technologies in place.
What workflow you think surprises care teams once they start using BlueFletch that really has the most impact? As one of the things that I was thinking about also, like we talked about the devices and their location, and now it's like, all right, well, it'd be interesting to hear like what you're hearing from the field.
To me, I would almost say the opposite. If somebody notices something, then it's probably not doing the job it should be doing. A lot of the things should be transparent, and it should feel like it just works. Like Lee was just saying, you pick up a device, I tap my badge, my screen comes up, and it's all the apps that I use. I don't have to go find things. I don't have to hunt things down. And I feel like the thing that might surprise me is the tolerance that people have for really bad existing processes. Like when I go talk to somebody and they're like, you ask them, how many times a day you log in? They're like, oh, about 20. And you're like, what? You type your username and password in 20 times a day to get in different applications. And they're like, yeah, it's fine. And the tolerance for that is more surprising to me than the experience that that people have with some of these newer technologies. To me, it's I think Tesla did a really good job of this, in the last like 10 years of like, setting a good example of here's what a good experience in a car should look like. And I feel like all the other car manufacturers had to follow that. I feel like that's how I think about things, is that when you use a system, you shouldn't have anxiety. You shouldn't have to worry about things. It should just work the way that would be natural to you. And to me, I feel like if nurses notice something with BlueFletch, we may have done something wrong. I feel like the flip side is probably more true. Lee, what's your thoughts?
I think that's a really good point. I'd say not so much from the end user side, but from the IT operation side, there's often a really good before and after picture if you look at just side by side comparisons of length of time to log into an application from one user to using username and password to the other user using like an NFC badge tap or something like that. It's often, a matter of 2 to 3 seconds versus anywhere from 20 to 40 seconds, depending on how complex it is. And if you do it right the first time. So I think when you look at application usage and metrics of on-device adoption, I think that's really where, from an ROI perspective, that's where operationally organizations get a lot of encouragement and reassurance that what they've deployed is actually solving the problems that they were perceiving prior to that. But yeah, to Brett's point, I think it should be as seamless as possible on that device. So you just pick it up and basically just pick it up and go.
And one more point on this, I know we're coming up at the end of the time, but like the thing that, and Lee talked about the IT teams, there's the one thing that has surprised me is if budgets are tight in hospitals. A lot of hospitals don't make money. They're what is it, like 60% of hospitals are nonprofits where they're getting donations from a lot of people. So it's there is tight budgets. And one of the things I have noticed is that IT will have this, let's go spend $500,000 to improve login for, our 1,000 nurses, or, we need to buy a new X-ray machine for this department. And they have to make a decision of choosing one of those things versus the other. And you really, really have to cost justify a lot of the IT spend versus a lot of the operational infrastructure spend, and it's tough for IT departments out there. So I think having a lot of the things Lee was talking about, having metrics and being able to look at it, point at it and say, hey, we saved 20 logins times 40 seconds times, 600 nurses a day in this facility. It makes that a lot, really, really cut and dry for the IT teams to be able to say, this is a worthwhile investment. We do have other things we can invest in, but this is something that's going to save us money. And
you have some of that reporting,
care.
Right? You have some of that reporting where it tells you this, right?
Yeah, we have all that reporting. We can surface that, and we can help. A lot of times in POCs, when somebody tests out BlueFletch, we run that. You run across like 10 nurses and like, hey, these 10 nurses saved this much time. And you don't just have the feedback of the nurses saying, yeah, it worked great. I tapped my badge, it worked. You have the actual hard numbers that you can take up to the board and say it's worth investing in this type of technology.
And I want to talk about POCs, but I also want to ask something about the systems. I know we touched on this earlier, but all these investments that organizations have in IT stacks like MDM, it's not that they have to replace these things if they go with BlueFletch. Everything can coexist with one another. So, like, for example, like what I'm really kind of seeking an answer on is like invalidation is if I have investments on another single sign-on technology, whatever it is, and I want to look at deploying, maybe a solution like BlueFletch next to it, I can deploy these things and still keep operating in the sphere that I'm operating in, right?
That's correct. And typically what we find works is um, if there's a single sign-on solution deployed system-wide, for example, but there's perhaps an interest in experimenting or exploring BlueFletch, we can take a small subset of devices in a small subset of a facility, for example. I mentioned phlebotomy earlier. There's also specimen tracking where things are very scan heavy, very resource tracking heavy, from that perspective. So it's a good place to see a good before and after picture of, is it better before BlueFletch or after BlueFletch? And you can, run that in parallel and not replace an existing system. Where we find good opportunities to start these types of tests, aside from just say a subset of a department or something like that, is also when organizations are considering, perhaps a new device rollout or a device refresh. If they're end of life on a particular set of devices and they're looking for another solution, that's a good time to do it too. You can deploy on, say, 5 or 10 devices at one facility rather than going in and replacing everything. From a BlueFletch perspective, we found that's the best way to set up success metrics, go in, spend a discrete period of time, and then make a decision from there on, is this working or not? Or do we have some unanswered questions that bear a little more testing?
So it sounds like it's pretty easy to, if you want to do a pilot of devices, you can roll out a pilot pretty easily with BlueFletch. Is there any specific departments that are utilized first, like transport or EVS? Is it something, that you see over one department over another?
I think not necessarily. Typically, what we try and talk about is a use case where there can be, like I said before, like a good before and after that's easy to measure with a relatively small subset of devices that's going to be somewhat isolated in terms of interoperability with the processes that other departments are practicing. So you want to try to disrupt as little as possible and answer the hypothesis as quickly as possible. The setup for that typically is 2 or 3 working sessions of an hour to an hour and a half. We can have single sign-on working in the applications that are deployed, to a department as an example. And then from there, we'll work alongside that team from a testing and evaluative perspective, changing the configuration on the device. Once it's in the hands of those end users, once we get feedback, we can go on the ground and do like a follow along or a day in the life kind of thing is often very helpful. Because what you're hearing from operations and IT on how a device is used or what a process is can be radically different when you get on the ground and see what people are actually doing.
Yeah, that's a good call out there. So CMS and rural health transformation, there's more money now for deploying technologies and other operational gaps that organizations are trying to fill. What advice would you give to those types of institutions or even larger institutions that are looking to roll out mobile technologies for the first time?
It's a good follow on for what Lee said. Start discrete, go pick a department and go pick something where you can easily measure. I think the biggest problem I've seen with a lot of organizations is they try to boil the ocean. And I get the reason why they do this is because when you have to go to the budget team and get budget for something, and going and getting budget for multiple things, if it's the same thing, it's a painful process. I've done this before where it's like, I need, $200,000 for a POC budget. And then we may come back in 3 months and do another 2 million for a larger POC, and then come back for 10 million for the full scale rollout across all of our facilities. And the problem with that is that it's just painful to have to go to the board back and forth. So a lot of people will just be like, we're going to get a full budget and we're going to ask for $20 million once, and try to roll everything out all at once. And that is it's a recipe for struggling or getting locked into a solution that doesn't actually work for your end users. I think the iterative approach, doing a pilot and having things go wrong in the pilot, finding those out before you deploy to tens of thousands of users is the way to do things. So for me, it's if, for these organizations, I know I'm not giving you the exact answer. It's sort of the it depends answer, but the real answer is, start out discreetly, prove the value, don't try to boil the ocean, and then add on, layer on as you go. You can always come back and add more things later and improve the solution, but start with a good base solution that solves the core problems and does the things that your clinicians and healthcare workers need.
I'd add on to that, Brett. It's you start with a hypothesis, right? Of we think the use case that's going to improve what we're trying to test is X. But just because the hypothesis maybe is proved wrong doesn't mean you still didn't learn something. And what you see too often is someone will go out in a test environment, have a hypothesis, the hypothesis is proven wrong, and say like, well, we're already committed to this tech stack, so we're going to roll it out anyway. So again, I want to acknowledge that it is frustrating from a budgeting and timing perspective, but it's going to be more successful long term. And all of us have been parts of deployments that took months, if not years, and millions of dollars, and then it never went anywhere, and then creates a bad taste in everyone's mouth, and then it never happens again.
Yeah, no, it's definitely it's complex to roll these out, any type of technology out, especially in healthcare. There's so much regulation. There's a lot of personas involved. From a stakeholder perspective, it's not as cut and dry as it is to walk into a small business and sell them a solution. It doesn't work that way, unfortunately. So where can we see the BlueFletch solution? Like, there's some upcoming events that I believe you all are attending. Like, where are you going to be this year so folks can see the BlueFletch solution?
Yeah, in the coming weeks, we'll be at Vive, which is in Los Angeles, starting on February 22nd. And then quickly following after that, we'll be at the HIMSS conference, which is in Las Vegas, starting on March 9th, I believe. In both cases, BlueFletch has a booth. So you'll be able to stop by the booth and see the single sign-on solution that we've talked about on the device environments that we've spoken of, meaning Android, iOS, and Windows. And you'll get to see and play and touch those features yourself and understand what that look and feel looks like, and understand what could be possible depending on your needs and your environment.
Great. So requesting a demo, if anyone has follow-up, what's a great way for folks to reach out to you for scheduling these types of conversations?
Sure. So obviously at the events we just talked about at the trade shows, but if you go to bluefletch.com/healthcare, you can request a demo there, and someone from BlueFletch will reach out and get an environment set up for you and walk you through the testing configurations based on what your needs are.
Awesome. We'll also have at Vive, we'll have the BlueFletch ecosystem running at the ProMobix booth as well on devices. So we're excited to be able to showcase that and have conversations. Final questions and thoughts. This has been a great discussion. I really appreciate both of you coming on the show today. One final close is like, where do you see frontline mobility going in healthcare? Like, is there any big things that we should be thinking about ahead?
I got one thing. So we've, for BlueFletch, we're always trying to think about what's next and get feedback. And one of the things that did come up in that healthcare survey that we did for frontline nurses that Lee had mentioned earlier was there was a lot of people that want to use biometrics. They want to be able to not have to have badges. They don't want to have to use username and passwords. They want to be able to use their face to log in, just like we all do with our personal mobile devices, or I think like 93% of Americans do with their personal mobile devices. So BlueFletch has built a agentic login module that allows biometrics, and we've been testing it in some other industries, and it is something that I see us introducing to healthcare very soon. There are certain downsides of things. If you're wearing PPE on your face, you can't actually use a lot of the biometrics, and the thumbprint is never really a ideal thing if you're using a shared device. But with face rec in those other scenarios, I think we're going to see that get rolled out and get adopted in certain organizations for certain use cases alongside the existing badge tap here in the next 6 to 12 months. So I'm excited about seeing that one. And then I think the other piece is just a lot of integration. So we're doing, like Lee mentioned, we are working with Epic on some of their newer tools and getting certified in those, working with some of the other EHRs. And we'll see a lot of that as we work with more and more of these customers.
That's interesting. One final thought on that topic of like the facial recognition. Most of that today lives on the device in like the iOS world and Android world. So this sounds like that's being moved up the stack and into the to the operating layer, right?
It's a little more complex depending on the device and the operating system. So for Google and Apple have certain requirements around privacy and security on the consumer side, but on the enterprise side, you need to be able to support these things at scale with shared devices. So there's certain complex models, and also, like you said, the things that get pushed down to the devices and synchronized and allow you to have that instantaneous login. There's a lot of complexity there, and I'm not gonna give away all that secret sauce, but it's been an incredible amount of work our dev teams have put in to make it seamless. And I think the description our CEO has is that if you notice the AI, it's not working. Which I every time I see something and I'm like, this is AI, I'm like, it's not working. But the ability to have something just seem magical is, I think, what we're trying to achieve. And with this, and I feel like there's certain levels of expectations we'll have because of our personal devices that that's going to creep into the enterprise and the healthcare organizations here over the next few years.
No, that's great. This has been a fantastic discussion. Like I said earlier, really appreciate both of you coming on. We're going to be at the Vive event, it sounds like, together. Looks like HIMSS as well. So look forward to seeing everyone there. Thank you again for tuning into today's episode with the BlueFletch team, and we look forward to seeing you at the upcoming events this year.
Excellent. Thank you.
Thank you.
Healthcare on the Move isn't just a podcast. It's a movement transforming healthcare through collective wisdom and innovative thinking. Each episode challenges listeners to move beyond passive understanding to active engagement in reshaping our healthcare landscape. If today's conversation sparked something within you, share your insights, subscribe, and help us drive meaningful change. Because transformative healthcare happens when we move together.